right, we'll move on to the next speaker. It is my pleasure to introduce Dr. Yaeger. Dr. Yaeger is a dual-trained endovascular neurosurgeon who specializes in treating vascular disorders of the brain and spine. He completed his residency and fellowship in neurosurgery and endovascular surgery at the Mount Sinai Hospital in New York City. At Mount Sinai, he completed a biodesign fellowship during which he invented and patented a new catheter for minimally invasive treatment of brain AVMs and aneurysms. Prior to his residency, he attended medical school at Georgetown University School of Medicine in Washington, D.C., and for his undergraduate degree, degree in biology, Dr. Yaeger attended Lafayette College in East Pennsylvania, and he's originally from North Shore of Boston, MA. He's one of our fantastic teachers, as any of the neurosurgeon residents will tell you, and he's been really made a great impact in the lives of our patients. He's going to be talking about the updates in management of Moya Moya disease and syndromes. Dr. Yaeger.
Wow, I'm very honored by that introduction. I am relatively new here. My name is Kurt Yaeger. I'm as Kevin said, endovascular, cerebrovascular neurosurgeon from New York City. And I will be talking today about the updates on Moya Moya disease and Moya Moya syndrome and what we've been doing over the past 5-10 years in treating this condition, diagnosing and treating this condition. It's still not quite really well understood. For a little bit of background, for those of you who don't know, Moya Moya disease is a progressive condition where the internal carotid artery terminus becomes stenotic and occlusive, and collateral vessels form at the base of the brain and create a characteristic puff of smoke appearance on the angiogram. So it kind of looks like this, with the distal internal carotid artery becomes narrowed and occluded eventually, and then the collaterals form, pedal collaterals form at the base of the brain. This can either cause ischemic or hemorrhagic presentations, depending on the friability of the vessels and depending on the state of the patient. If they're dehydrated and stuff like that, they can have ischemic presentations. If the vessels are very friable, they can have hemorrhage, or they can also have pseudoaneurysms or small aneurysms form at those friable vessels, causing a hemorrhage. As a bimodal age of onset, usually the first decade of life, pediatric patients present with this condition, and also a subset in the 30s and 40s also can present with Moya Moya disease. Women are definitely more common than men in this disease, and the incidence can vary between East Asians. It's much more common than the rest of the world. In East Asians, it's 0.5 to 1.5 per 100,000 people, so much more common than populations here. So one of the most important, so getting into more of the updates, the most recent diagnostic criteria were released in 2022 based on the research committee in Japan looking at their population. Since the population is more frequent there, they do a lot of research in Japan and South Korea on Moya Moya. So they release these diagnostic criteria. So they look at either diagnostic cerebral angiogram, catheter angiogram, or MRI as two separate entities, although they push more towards angiogram to make the diagnosis because you can use the angiogram to exclude other things like atherosclerosis and and vessel occlusions, things like that, with angiogram rather than MRI, which may be a little bit harder to diagnose on. So for angiogram, the two requirements are stenosis or occlusion in the distal internal carotid artery territory, and then Moya Moya vasculature collateralized around that circulation. And it can be unilateral or bilateral. On MRI, it's a little bit different. There's three criteria. Number one is a stenosis or occlusion of the ICA terminus. Number two is decreasing the outer diameter and the inner diameter, the inner lumen on time of flight MRI, and T2 MRI. So T2, you see the flow void, the outer lumen, or the outer diameter of the vessel is very narrowed, and that's necessary for the diagnosis on MRI. And then lastly, you see abnormal vascular networks within the basal ganglia. I'll show you some examples of that in a second. But those are the two, either angiogram or MRI scan to make the diagnosis. But then most importantly, all the conditions in B here are needed to be excluded to make sure to have the diagnosis of Moya Moya disease. If any of those differential diagnoses can be entertained, then it would be more like a Moya Moya syndrome or quasi-Moya Moya disease, where you have pathologies like lupus or meningitis, certain type of tumors. Post-radiation, those changes can be found and need to be excluded prior to making the diagnosis. So on angiogram, this is pretty characteristic. You have stenosis of the distal ICA and then collateralization of the lenticulostriate vessels or the posterior choroidal arteries in the basal ganglia region. The Suzuki grading system is relatively well known, but basically describes the progression of the disease starting with narrowing of the vessel, the ICA, and then stage 2 and 3, developing more and more Moya Moya collaterals, and eventually the internal carotid artery becomes occluded, and the external carotid artery becomes more supplied to the cerebral circulation. Eventually, the Moya Moya changes then decrease as the external carotid circulation takes over, and then finally, Moya Moya changes disappear in the kind of the most severe stages. On MRI, on time of flight or a 3D MRI scan, you can see distal carotid artery occlusions, and then here are on the MRA the flow voids you see in the collateral circulation in the MRI. Other findings, so you can do vessel wall imaging, and you see concentric enhancement of the vessels, and most importantly, a decrease in the diameter of the vessels, the outer diameter of the vessels. With things like atherosclerosis, you'll see the outer diameter maintained, but then the inner lumen is smaller, so that's the key distinguishing factor. Also on flare, you can have something called the Ivy sign, which is flare signal in the sulci, which can represent collateral flow from cortical impeled circulations. Some newer techniques, relatively newer techniques being used are CT and MRI perfusion and PET-CT, looking at the response to acetazolamide. So in this part A, this is pre-vasodilation with acetazolamide. You have a decreased perfusion in certain territories, and then as a response to acetazolamide, you see increased perfusion. And what this is in particular used for is assessing patients' candidacy for surgery. If certain regions don't respond to the autoregulation of the body, then they're better candidates for surgery. Also, in addition to CT perfusion, MRI perfusion, we've been using arterial spin labeling MRI sequences to better correlate with PET-CT. Not all centers have the ability to do a PET-CT, so arterial spin labeling MRI has also been used to help diagnosis based on the vasodilation. So another part of the kind of the newer interest in Moya Moya is defining the genetic pathways. There's a lot of genetic pathways to consider in Moya Moya. One in particular, the RNF213 susceptibility gene, is quite common. So overall, 10% of patients have some kind of familial inheritance to Moya Moya disease. And of those patients, especially in Japan and South Korea, up to 90% of those patients have this susceptibility gene. Now, there's kind of a spectrum in terms of presentation between completely asymptomatic patients and completely carotid occlusion patients. And we're not exactly sure how that distinguishes, how that is made. But there's 16 genes in this kind of diagram. Don't want to spend time going into all of it, but there's a lot of information here. And nitric oxide is also an interesting one that a lot of research has gone into. Nitric oxide is presumed to play a role in remodeling flow-related problems in the ICA terminus, where there's a bifurcation. The flow is bifurcating, and there's disruption at the ICA terminus, and that is one of the hypotheses is why nitric oxide plays a role in limiting the progression of Moya Moya. One of the recent thoughts is more of a two-hip hypothesis, so patients can have a genetic predisposition to Moya Moya, such as RNF213 gene, and then there's some kind of environmental factor, some kind of inflammation or autoimmune process that goes on to actually precipitate the progression of the disease. So that's one recent thought, although there's not a lot of evidence to support that so far. We've got to wait. Is there a better solution? Okay, thank you. All right, so this is what I mentioned a little bit before, was the RNF213 related vasculopathy spectrum. So patients with the same genes can have either asymptomatic presentation with preservation of flow on the perfusion scan, up to complete Moya Moya disease where you have strokes and occlusion of the carotid artery with poor circulation. So we're not quite sure and understand why this goes on, but it's a region of interest recently. So the most recent natural history data suggests, so there's 3 different ways to present. either incidentally with asymptomatic presentation, hemorrhagic presentation, or ischemic presentation. So the most recent data suggests the 5-year risk of a recurrent ischemic event is up to 65% in unilateral cases and 82% bilaterally, so quite high. Hemorrhagic patients have a 30 to 60% long-term rebleed rate, so that's also quite high. And then asymptomatic patients do have an annual stroke incidence of 5%. So the medical treatment of Moya Moya, the most recent guidelines from Japan were published in 2022, but from the 2021 meeting. And we'll talk about that now as more or less an update to the management, although the management hasn't really changed too much in the past few decades. First, in the acute presentation, consideration should be given to IV for ischemic presentation, IV thrombolysis and antiplatelet agents, although you have to weigh the risk and benefit with the patient individually about their risk of bleeding. If patients who have hemorrhage, systolic blood pressure control is indicated, and as well as reversal of any antiplatelet or anticoagulation, and also any type of neurosurgical intervention acutely, such as ventricular drain or decompression. For chronic and prevention, aspirin is definitely the first line. I'll show you a slide in a second, as well as salacitol, which is a vasodilator agent, and clopidogrel is the second line. In symptomatic patients, definitely for prevention, those medications should be used, but cautiously in asymptomatic patients given their hemorrhagic risk. Also, for patients with Moya Moya headaches, definitely avoid triptans and other vasoconstrictors, and also medications that lower the blood pressure. So those are the most recent guidelines from the Japanese study group. This is a recent study looking at nationwide patients in Korea, so tens of thousands of patients, looking at their risk of recurrent event long-term based on these medical agents. Aspirin and salacitol are definitely at the top in terms of prevention, so that's why they're the first line treatment. Surgical management, this has not changed in many years, but the goal of surgery is for patients with ischemic presentation, is delay the risk of recurrent stroke or TIA and improve neurocognitive function with increasing the flow. Patients with hemorrhage, there's been some randomized trials looking at patients with hemorrhage who have surgery, and surgery can reduce the risk of recurrent hemorrhage. I won't go through the exact details, but the two basic philosophies are direct bypass, where a vessel from the superficial temporal artery is plugged into the middle cerebral artery at the sylvian fissure, and then indirect bypass is laying a strip of the superficial temporal artery over the sylvian fissure and allowing the collaterals to fill naturally. This is the two strategies in a nutshell post-operatively in regards to the flow. And with a direct bypass, you have immediate flow increase right after surgery. But something like an indirect bypass where you are just laying a strip of gallia and maybe muscle on the brain, it takes many months for the flow rate to increase, and even so it does not reach the full flow rate as a direct bypass. The most recent meta-analysis from, I think, 2022 showed that both surgical techniques increase the favorable outcome rate. However, indirect bypass has a slightly lower rate of favorable outcome, so about 81%, versus a direct bypass or combined bypass, which is direct and indirect, which has about a 94% rate of favorable outcome. So unfortunately, I don't know why that slide came out like that, but unfortunately, there is no role for endovascular management at this point. Acutely, it's very contraindicated to do angioplasty or stenting. The only indication for endovascular treatment would be if there's some kind of aneurysm or pseudoaneurysm, even though with aneurysms, if you do a direct bypass, those aneurysms tend to get smaller over time anyway. So at this point, there's still no role for endovascular management. Most of the information from this slide came from this October 2023 AHA American Stroke Society statement on Moya Moya disease, so I encourage you to read that and get some more information, but that's pretty much it for me. Thank you.